We're live.
Good afternoon and welcome to Calderdale and Kirklees Joint Health Scrutiny Committee. I wondered if members of the committee would like to introduce themselves. Councillor Hutchinson, do you wish to start, please?
Councillor Colin Hutchinson from Skirkett Ward in Calderdale. I'm co-chair of this committee.
Thank you. Councillor Collins.
Hi, I'm Councillor Anne Collins from Calderdale, Councillor for Ovenden and Vice Chair of our Children and Young People Scrutiny Panel.
Thank you. Councillor Breakborough.
Thank you. My name's Councillor Howard Blagger. I'm a councillor for Brighouse, Chair of the Adults in Calderdale and serve on the Children and Young People Scrutiny Panel equally. Thank you.
Thank you. Councillor Swift.
Hello, I'm Megan Swift. I'm a councillor for Town Ward in Calderdale and are on things like adult health, etc. So, yeah, that's me.
Thank you. Councillor Cooper.
I'm Councillor Andrew Cooper. I'm a ward member for the Newsham Ward in Huddersfield, and I'm chair of the Corporate Scrutiny Panel.
Councillor Simpson.
Hi, I'm Councillor Will Simpson in Denberdale Ward in Kirklees.
Thank you. And we've apologies from Councillor Munro, and I'm Councillor Liz Smage from Kirklees, and I'm joint chair of the committee. Thank you. Item 1 then is minutes of previous meeting. Do we have any points that we wish to raise on the minutes of the meeting? First of all, Councillor Hutchinson.
You're on mute.
There were a couple of matters arising from the minutes of the last meeting. There was a request for the Trust to liaise with the West Yorkshire Combined Authority around the question of bus services between the sites and from the towns of Calderdale, of Halifax and Huddersfield. And I was Councillor Groves, who chairs that committee, had told me that she would make progress with that. I'm not sure whether that has happened, so I would like confirmation of that. And similarly, there was mention that information would come back to this committee about a new health centre in Brighouse, and I'm not aware that that information has reached us yet.
Okay, thank you. Anna from the Trust, do you want to just address those matters before we approve the minutes?
Yes, thank you. In terms of the liaison with West Yorkshire Combined Authority regarding provision of bus services, there has been a number of meetings held and liaisons with the authority. That has had some interruption on our pace of progress in relation to the pandemic. My colleague Nicola, who is also available, could provide more detail regarding that dialogue and progress, and you might want to pick that up as part of the item later on the agenda.
Thank you.
In terms of Brighouse, the query there, I believe, was a query that at the time Matt Walsh was taking back away to respond on, so I don't know if that's a query more for the CCG colleagues.
Yeah. So the CCG colleagues, do you want to bring that up under item 6? We'll take it, yes. Okay, so any other points that anybody wishes to raise at this time? Do we therefore agree the minutes of the meeting? Yes? Yeah. If the committee can indicate yes, that's fine. Thank you. Thank you very much. Thank you. Okay, then. So any councillors got any interests they wish to declare? No, thank you. And all the items are on the agenda are public items, and we are live streaming today. We have 2 deputations, and can I ask Richard to read those out, please?
Yep. Thank you, Liz. The first deputation we've got is from Christina George, who's doing this on behalf of Hands Off HRI. The update provided to the committee at agenda item 6 repeats some of what was presented at the last meeting in terms of consultation. It is vital that we see more about how the Trust intends to involve members of the public in their ongoing plans for the reconfiguration. According to the Trust's own figures, 121 people attended 4 workshops last year. Over 100 attended 21 colleague involvement meetings and 15 young people at the youth engagement event. Out of a population of over 250,000, these figures do not constitute a meaningful or worthwhile consultation. The period from October 2020 to February 2021 is critical to the consultation, and we would ask the committee to press for more detail as to how this critical consultation will be undertaken and how the views of the public will be included in any future plans. We clearly need to hear the plans the Trust has made to engage with all disadvantaged and minority groups, particularly the elderly and those with sensory and other disabilities that exclude them from common methods of communication used in consultation. We feel that any ongoing consultation should really reach out to the local community and include those who have many unanswered questions on the way forward for healthcare across the 2 councils. Hands Off HRI has in the past demonstrated its interest in the future plans and how it has given a voice to various underrepresented groups, and we would hope the Trust would involve us in their future consultation plans. So far, we have not been made aware of any consultation event. Remote working and consultations have been a necessity over the last months, but our feedback is that in most cases, it is clear that most of the public would not want this to be the way forward. The opportunity for face-to-face consultation is critical to identifying and addressing health inequalities, mental health and safeguarding issues. Nationally, we know that experts feel there's a real issue with all of the above, and we would wish to see the Trust and CCG have plans in place that will address this in the coming months. A recently published paper, NHSE/NHSI Phase 3 COVID-19 Priorities, proposes a policy direction towards a single CCG for each of the 42 ICS footprints. This would likely result in mergers across the board. As a campaign, we would appreciate the committee investigating this further and identifying the impact this is likely to have on the future shape of CCGs and the implication for our hospital and care services moving forward. In addition, it's been brought to our attention that there are significant savings required by the Greater Huddersfield CCG in the coming financial year, and there is a need to understand how this might impact on the services in primary and secondary care and the knock-on effect this will have on future plans for reconfiguration. So that's the deputation from Christina Jordan, Hands Off HRI. We've then got a further one which came in from Jenny Shepherd. 1. Read the update on primary and community services. Please will the Calderdale and Kirklees Joint Health Scrutiny Committee affirm that its business is to scrutinise the care closer to home /PCN integrated care plans for the whole CHFT footprint and make sure that it does this thoroughly. 2. Why does the Calderdale and Huddersfield Service Reconfiguration Update Report for the Calderdale and Kirklees Joint Health Scrutiny Meeting make the misleading statement that these changes to the delivery of community services are subject to separate place-based scrutiny in both Calderdale and Kirklees? When there was a clear challenge to this arrangement in the last JOSC meeting in October 2019 by Councillor Colin Hutchinson, he reminded the committee that at some stage they have to tell the Health Secretary whether or not they are satisfied that the revised plans meet his 3 requirements, which are further work focusing on out-of-hospital care, hospital capacity, availability of capital. He pointed out that the Scrutiny Committee needed further information about progress to increase care in community settings that would allow the Hospitals Trust to work within the planned bed base. The NHS organisations provided little information in that meeting about progress to increase care in community settings. Moreover, Matt Walsh seemed to try and divert this scrutiny by responding to Councillor Hutchinson's statement with, and this is a quote, "We need to think about the relationship between place and this community." Translated, that seems to mean he wanted the place, i.e. individual council health scrutiny committees, to scrutinise their area's clinical commissioning groups' care closer to home plans, rather than the Calderdale and Kirklees Joint Health Scrutiny Committee scrutinising both the Greater Huddersfield and Calderdale care close to home plans. It was not the first time in this scrutiny committee that he made the same point. Councillor Hutchinson replied, quote, "This committee has to respond to the Secretary of State. No interest in duplicating work that's going on in council scrutiny committees, but we do need to be able to respond to the Secretary of State in due course." 3. It is very worrying that there is so little information about care closer to home. The shift out services out of the hospitals in the current documents of scrutiny, and what there is a skimpy affirmation that the experience from the pandemic is that the continued integration of services is able to be implemented at pace across primary, community and social care. The fact that this is possible doesn't mean it's desirable, and we know from the West Yorkshire and Harrogate integrated care system and from members of the public that there are serious issues about restoring elective care in the COVID-19 reset. We also know that in Calderdale at least, GPs are inundated and finding it very difficult to balance their on-day response to patient needs with other needs for GP services. Please will the committee make sure that these issues are properly scrutinised in this meeting and they don't just note the update as it recommends. 4. Relatedly, ONS data shows a big rise in deaths at home over past months. Please will the Scrutiny Committee find out what the end-of-life care in the community services have been able to do to provide appropriate good quality care to people dying at home in Calderdale and Kirklees since the last scrutiny meeting 11 months ago, and whether and how the need for their services has risen in line with data about increased numbers of people dying at home. 5. Finally, we know that many care home residents died of COVID-19 after NHS England ordered the mass discharge of patients at the end of March in order to prepare for an influx of COVID-19 patients. Please will the committee find out what arrangements are now in place for the safe discharge of hospital patients to care homes and to their care after discharge. And that's it.
Thank you. We don't have any public questions, so we move on to item 6, which is the update on reconfiguration of hospital services at Calderdale and Huddersfield NHS Foundation Trust. We have representatives from both the Trust and the CCGs here with us today. This update was to be given in March, but we had to obviously postpone our meeting. So the update will be as from what the current picture is, I believe. Anna, are you going to lead on this, Anna, and the CCGs come in?
That's correct. Thank you very much. Hello, my name's Anna Basford. I'm Director of Transformation and Partnerships at Calderdale and Huddersfield Foundation Trust. We've provided an update report for the committee today, and it covers 4 areas. The first is to provide a general update on the programme and the timeline. The second is to share the feedback that colleagues and members of the public gave about the key principles they would like to see taken forward into the design of buildings. And as has been referenced by Councillor Smage, that element of this update would have come to the committee in March but was deferred. It goes on to talk about our future plans for continued public involvement, and it also provides an update on progress in the development of community care provision. So I'll just talk to the first 3 items and then hand over to Neil and Carol in relation to the community services. So in terms of the general programme update and timeline, the report details the timeline that we are currently working to. We have agreement with NHS England and the Department of Health that we are currently developing a full business case for the developments at Huddersfield Royal Infirmary and an outline business case for the developments at Calderdale Royal Hospital. Both of those business cases we're targeting to have completed by June 2021. What that would mean, the completion of those business cases in terms of the overall programme, is that should, subject to approval of the business cases at Department of Health level, allow us to commence construction works at the Huddersfield site in late 2021 with a completion in 2023. And for the Calderdale Royal site, we would have a further stage of business case development that would lead to construction commencing in 2023 and completion in 2025. So those timelines have moved from the position we were at in March earlier this year. We've incorporated into that revision of the timeline some delays, the obvious delays that we've experienced during these difficult months of the pandemic, when there are some aspects of the work we've not been able to take forward, particularly regarding some aspects of face-to-face clinical and public involvement, and also around on-site work of some technical surveys that we've needed to undertake. So moving on from the timeline, I'll turn to the design brief. So at the end of 2019, we invited a large number, we sought to have as wide a reach as possible to invite members of the public to participate in a number of workshops alongside architects that we'd appointed to tell us about what matters to them regarding the design of healthcare buildings. At the time, we arranged for 4 workshops, and we were very much in the stage of that should we have more people wishing to participate, we would have scheduled more workshops. We held the 4 workshops. We also held a number of colleague and staff workshops, and as a result of that, what's been included in the paper today is a link to the detailed feedback and process of involving staff and involving members of the public, and then the output from that, which is a design brief document, which is not the design of the hospital, but it is those key principles about what is important to people about the environment in which care is delivered and the functionality of those buildings. The third element of the report that I'll just give a brief introduction to is around our continued work regarding the involvement of members of the public. And indeed, we've already done an important aspect of that. One important aspect of that is that when we developed the design brief, it was a point in time pre-pandemic. So since then, we have undertaken some further public involvement through a public survey regarding people's experience of accessing services during the pandemic. And we will be overlaying our learning from that into the design brief document to make sure that we really are making any adaptations to the design that would give greater future proofing and resilience going forward in terms of the environment in which healthcare is provided. Our next steps for involvement are a very strong commitment for the continued involvement of members of the public, our colleagues and our stakeholders. We've set out briefly in the paper some of the key stages of that involvement in the coming months up to the production of the business cases in June. You will see that during this period now going forward, October, November, we intend to undertake wide-ranging stakeholder and informing public around the stage of the programme that we're at, and that we will be scheduling further public involvement sessions regarding the design I noted the comments that were made during the earlier deputation, and I would welcome any comments about how we involve members of the public. Face-to-face meetings are difficult and challenging, and we definitely want to give every opportunity we can. So any suggestions regarding that, I'd be very keen to hear. I'm going to hand over now to Carol and Neil, who will talk to the update regarding the development of community care provision.
Thanks, Anna. Perhaps shall I go first then and say a little bit from a Kirklees perspective, and then hand over to Neil to speak about Calderdale. So I'm conscious that the last update we had on this to the committee is coming up for a year ago now, and I wonder if it might be helpful to say a little bit about what we've done in the last year. Firstly, it's almost like pre-pandemic and since the pandemic happened, if you like, 'cause there's two separate 6-month periods there. I think if I could just remind the committee that in the past we have talked in Greater Huddersfield about the strategic commitment to developing services out of hospital, and the fact that we have matched that strategic commitment in our financial plans. I think just to correct a statement that was said earlier about Greater Huddersfield facing a significant financial challenge, that isn't correct. Greater Huddersfield finished the last financial year in surplus and has exceeded its financial plan. So I just wanted to address that one. Over the last year, we have done what we can to try and deliver against that strategic intent around services in our community, and we've been able to make some positive investments. An example of that is investing in Locala, our community provider, to enable them to appoint new staff who would be based around primary care networks, because it's really important that primary care networks have dedicated members of staff working with the general practices and other professionals in the localities to really understand the needs of those particular populations. We also agreed to invest further in the rapid response service that's run by the council to enable us to deliver a quick response to people who require something in their own home, which ideally helps avoid admission to hospital. So a couple of examples there in terms of investment, and as that has been going on, we have continued to focus on the development of primary care networks across the whole of Kirklees. And we have seen them move on quite significantly and develop some really good partnerships with colleagues in other agencies such as the council. I think one of the things we're quite proud of in the Kirklees area is that at the turn of the year, on the back of some of the really strong partnership work we've been doing, we were awarded accelerator status for a programme called Urgent Community Response. We're one of 7 national accelerators, and the focus of that programme is on being able to respond to particularly frail members of the population within a defined 2-hour period to when they have that need, again with the view of avoiding admission to hospital where possible. But also the other element of the programme is about delivering a quick and timely response in relation to discharge, so that people are not staying in hospital any longer than is needed. So that was a really positive development for us in Kirklees, and the rollout of it has been delayed slightly on the back of COVID, but we anticipate going live with that work in November. Then I think it is worth just saying that obviously 6 months ago, when the pandemic hit us, we've had to sort of do what everyone else has done and adjust and transform rapidly, really, in response to the pandemic. And I think one of the reflections I've got on that is that it enabled us to make some changes that we have talked about for a long time, but which may otherwise have taken a long time to bring about. And we've been able to get some really positive learning from the experiences of the last 6 months. So, for example, we've seen general practice undergo a massive change at speed I've never seen before, and been able to continue to deliver services to people throughout the pandemic, albeit on the telephone, through video consultation, and also seeing people face to face where that is clinically necessary. And they have been, and I would just like to be really clear about this, they have been open and available over the last 6 months, contrary to what you might read in some of the newspapers, and delivering services throughout just in a different way. We've had to adapt, and we've had to make sure that those services can be delivered safely. And clearly having crowded waiting rooms in general practices where social distancing wouldn't then be possible would not be good for either patients or staff. So I think they have been very flexible, and they've been really, really impressed by the approach of general practice and how they have worked. I've also been really impressed by the way that PCNs and our colleagues in the Community Plus service have worked in Kirklees. They deliver a lot of services such as our social prescribing work, and they were able to come together very quickly and deliver sort of support, contact to some of the most vulnerable members of the population, and it was really helpful to see that those partnerships existed and could respond in time of crisis. The other thing I would note that the pandemic has sort of really shown us is the extent to which partnerships do exist and people have come together to work in a different way. So we have seen in Kirklees our GP federations working with Locala, our community provider, to deliver services such as assessment centres for COVID patients and a home visiting service for people who are either housebound or COVID symptomatic and unable to get out. And they again came together really quickly, were able to deliver that service as a partnership in a way that was very responsive. There's loads of other examples, and I think some of them are touched on in the paper, and they will apply to Calderdale as well. But as a system, we have responded with partners to the particular needs of people in care homes. The huge amount of work done there and I know in Kirklees Place there was a discussion on care homes yesterday in the panel session. But that, I think the reason I wanted to mention that is because all of the work that we have done over the last 6 months in areas like care homes will stand us in good stead for the future. It is not something that will just stop when the pandemic is over. You know, it is a service response. It is a partnership that will continue, and I think will really help make sure that we address some of the concerns that we've had in the past, perhaps about the number of residents from care homes who are being admitted to hospital, because we are now doing a lot of work to support care homes in terms of being able to manage some of these challenges as we move forward. So I'll maybe stop there and hand over to Neil to give a Calderdale picture.
Thanks, Carol. So I'm not going to sort of repeat what's been done to a couple of sort of local scrutiny sort of committees. We've done a couple of updates, particularly on the pandemic and what's been happening in the sort of care closer to home community agenda for some time. But a bit similar to sort of Carol, a tale of two halves. So just before the pandemic, as part of our care closer to home prospectus and alliance, our partners have been working on a memorandum of understanding for all our community providers to sort of sign up to, which is a huge step forward, and probably emphasises the way of working across the system that we've seen that's been sort of very much embedded during the pandemic. PCNs have probably come on leaps and bounds as a result of the digital first sort of approach, primary care access, and MDT working across community and primary care physicians has increased with pace, particularly during the pandemic. And I think, I suppose that a recognition of where our providers are in the community setting is that we've been able to start to deliver the care home DES ahead of sort of schedule and get agreement. Part of that is down to us having the community services with care homes with CHFT already and having some of those services already in place, but also recognising some of the maturity in our PCNs to start working in a multidisciplinary approach. That has enabled some really good work during the pandemic and the safe discharge and movement of patients between both the hospital and care settings throughout the sort of the pandemic, and ensuring that, you know, patients have remained safe at all times. Digital first is very much, I know, can be a thorny issue, and we're working very much, particularly with our sort of community going forward, as to what the balance between digital and face-to-face is, recognising that there is a growing requirement for a mixture of both economies in our community settings. And I think in the paper we've alluded to there how we have successfully transferred to a lot of digital and virtual forums, which is great. And I think we were on a trajectory to do more face-to-face. However, people will be aware of the sort of the change in the curve of the pandemic at this moment in time. However, we have been working very much with Health Watch, who have done a lot of community engagement with us about how there needs to be that balance between digital first and face-to-face. That's very much a priority over the next probably 6 months that we need to strike that right balance for our community services going forward to ensure that there is good access in a variety of methods, and that it's not just purely digital, but we recognise the needs of the population that we serve across our primary care networks. Short and sweet for Calderdale, I'm afraid.
Thank you very much. Thank you. Before I open it up for questions, I just want to clarify community services. Community services, we said in our original response that we would like to have concerns addressed that the proposed numbers of inpatient beds will not be sufficient to meet demand. The CCGs might develop a plan that demonstrates how capacity in community services will be provided to support the plans. Okay, so this committee is looking at how that capacity is there in community services, and I think the detail of what community services are will be looked at by the Calderdale and Kirklees panels. I think that is perhaps where the crossover comes in. Okay, so this panel needs to understand that the capacity is there in community services to be able to make these changes going forward. Okay. Also, I wondered, Carol, there was an item in the deputations that was brought up about a paper on changes to CCGs. Now, that is outside of this panel's remit, but I didn't know whether you just wanted to make a comment as to that particular item before we move on. Thank you.
I think that was referring to the statement in some of the recent national documents that talk about streamlining of commissioning arrangements, and tends to use the sentence that typically this will result in 1 CCG per ICS. We have, I think probably said in local panels as well, in West Yorkshire in the ICS, the view is that we are not typical because of our size and complexity, and we continue to take that view. And the fact that typically remains in the documentation, I think, recognises that 1 CCG per ICS is not necessarily the right answer for everyone. What we are doing is continuing to review how we work together. So we as a group of CCGs, you probably know we already have a joint committee in place, and that's been in place for several years now. And we continue to keep that work plan and its approach under review to see if there are areas that we could work together on more effectively, and where the outcomes would be greater if we work together. But we are aware of that national statement, and we are mindful of it, but equally what we're trying to do is shape a future that would work for us in West Yorkshire as a partnership.
Thank you. It is outside of the remit of this committee, but I think we just need to understand where the position is as it's been raised in relation to this work going forward. So that was useful. Thank you very much. And also there was an item that was brought up under the minutes about Brighouse. Can Calderdale CCG address that, please?
Yes, thanks, Liz. Can I just two things? One was the capacity thing that you talked about, and we probably talked about this more locally than here. That as part of the NHS England's investment, similar sums of money over the next 5 years are invested in significant amount of new roles in community and primary care, and we've been working jointly across the patch. In the last year, we've invested in social prescribers and physios, and the physios have been done jointly with CHFT in a partnership approach. So we have huge amounts of investment in new roles to ensure that the capacity is there for the community going forward. On the Brighouse issue, it's probably news to me that there's a development there. We are in conversations with all our primary care networks, but we haven't agreed a development or a new proposal in Brighouse. So it's a bit news to me as to sort of what that sort of action is, I'm afraid. You're on mute, Liz.
Oh, I think we should all have a sign, shouldn't we? Putting up, you're on mute. Councillor Swift, you had a question, I think.
Yes, a question, comment, all mixed up in one. And I can only really talk about the Calderdale GPs, etc. And this isn't a criticism of anybody who is working the system. It is a criticism of the system. We had a quite small doctor's surgery in the village, well, big village that I live in. Last week, social media had about 100 questions about what was happening with the surgery. Were the doctors coming back? They'd been told they weren't, and lots of other questions like that. And they're saying there's no transparency. So, and some of them don't believe there's a pandemic either. So it does get slightly difficult. Yeah, we haven't got anything that gives an indication to these people that either, you know, they're not coming back, they won't be back for 2 years, or how it is. And the other one, and I will be quick because Howard, as chair of our Calderdale thing, shut me up part way through. Yes. It's when you want a doctor, you know, and I think Annette said the last time I was at a meeting when she was there that people were happy with the system. They're not happy with the system at all. They're just putting up with it because they've got no choice. You know, you ring the doctor's surgery, you get a nurse. They say they'll get someone else. Later in the day, you've got probably a nurse practitioner. And then later in the day, if you're really lucky, you get to talk to a doctor. Now, you know, if you've got little ones or something like that aren't well, it's just taking too long, you know. And yeah, the pandemic is dreadful. And, you know, people are working really, really hard. But as for the local surgeries and the local doctors, they're obviously doing what they think gives the best service. But people out there don't understand why they've no longer got a surgery. Sorry about that. I know I go on.
It's okay. Thank you. Howard, did you want to come in before we ask for replies?
Yeah, that'd be really good, actually. Two things. I've got another question later on, but I'll come in later on. But first of all, Anna, you attended a really successful event last year in November, an older person's event, and it was a really great opportunity to actually showcase what you're actually doing. So thank you for coming and taking me up on that. I just want to come back on the potential Big House Health Centre, because it was something that Matt Walsh did go away and he did have a conversation with the owner of the actual land itself, because following planning permission being passed in Calderdale for a health centre. So I don't know if it's something that needs to be revisited on this particular matter and moving forward. So I'll leave that at this moment in time. I've got some other financial questions, but I just wanted to speak up on the Big House Health Centre.
Thank you. Before I bring CTG and CHFT in, I think it just needs to be clarified as to what plans are there for primary care, doesn't it? And Councillor Swift's comments, I think the paper is saying that you know, services have moved quickly in primary community care, and they have. And then you're talking about, I know much of the health service is talking about sort of restart and everything. So I think it would be good if you could address Councillor Swift's comments, but also say in relation to how those changes that have been made, will any of them be part of the services going forward in the reconfiguration? If you see what I mean, how are you going to restart services in relation to the configuration as they were previously, or moving towards what you need for the reconfiguration? Thank you. Does somebody want to come in on those points then before we have some more questions?
I'm happy to answer.
Apologies, Chair.
So hang on a minute, Anna and then Carol. Okay, go on.
I was going to say I'm happy to answer into relation to the hospital-based services, and then I was going to suggest Carol around primary care. So in terms of the learning from the pandemic, I referenced in the introduction, we have undertaken a specific piece of work to involve members of the public, colleagues and stakeholders to understand what changes in the ways of delivering services had to be implemented, but then to draw out from that those changes where actually they may improve access or provide options on access or improved experience in the longer term to build into some of our future plans for delivery. Some very obvious examples in relation to that are that in terms of the investment into the hospital, the question about what proportion of single rooms versus bedded bays should we build is informed by the learning in the pandemic that to have greater resilience of more single room provision will be potentially more resilient around infection prevention for the years to come and into the future. There are other examples, and I would just pick up on the comment, Councillor Swift, that you made around, I think the comment you made about where I said people were, perhaps some people were happy with an alternate form of access. I think that was in reference to digital access. And we have had feedback through public involvement. For some people, digital access is more convenient to remote consultations, not needing to travel. But I think also we also know very much from that feedback, there are some people where that is not the experience or they have difficulties using the technology. And therefore, we're not proposing 100% adoption around a digital future. What we want to do is get the right balance of that to offer optimal access and options, but recognising for some patients they will always need face-to-face contact.
Carol, did you want to come in?
Yeah, just a few points. I think some of the principles that Anna's talked about there apply just as much to primary care as they do to secondary. So services are, as I say, services have always been open in primary care, but certain things were suspended in the early days of the pandemic, and we are now actively working to make sure that everything is getting up and running again, and things like screening and other services are becoming operational once more. So there is that very practical element of the restart, but there is the thought being given to how we do things, and like you alluded to, are there elements of the way we've been working during the pandemic that we want to be able to draw through into the future. And I think some of the conversations that we've had with trust colleagues have been with that in mind. So in terms of how that relationship and dialogue works between primary and secondary care, we actually think that some of the principles that we talked about in the outpatient programme, for example, before the pandemic, we can use the learning of COVID to help us not necessarily look at referral to outpatient as the default action, that there are other ways of people being able to get a secondary care opinion into primary care in order to inform the right way forward. So there are examples like that, and I think with access for primary care, it's exactly as Anna said for secondary. We know that for some people, being able to have a telephone appointment or a video consultation is fantastic. It fits in with their lives. For others, it's a loss not being able to see their doctor face to face, and we know that from some of the feedback that we've had already. So we absolutely can't throw the baby out with bathwater here. We need to be able to develop services in a way that work for all members of the population and reflect those different needs, because it's not about moving wholesale to non-face-to-face working or anything like that, because we hear from primary care staff that's not what they want to do either. It's certainly not always best for them, so we need to be able to be adaptable. But I think if I just make a final observation, I think the one thing that we, more than anything that we have talked about during the pandemic that will have an impact on how we work going forward is health inequalities. So we have always talked on this area, I think, previously, but it has really been brought into very sharp view during COVID. And we have seen the disproportionate impact on certain parts of our population. And it's something that in Greater Huddersfield, we've been talking about what does it mean for primary care as well. So really starting to scrutinise what's happening in primary care. For example, are people with learning disabilities receiving the annual health check that they should be doing? And if not, what more can we do to help with that? What are the barriers? What's getting in the way? So I think that health inequalities agenda is something that is really going to strengthen as a result of our experiences over the last few months.
Okay, thank you. Councillor Cooper.
Yeah, three things really. One is there've been some comments about the consultation and the fact that that it's been a bit disappointing. So in terms of responses, so I think it's almost incumbent on, I think people are right, but I think it's incumbent on people to come up with some suggestions. And if you've got any suggestions about improving response rates to consultation, I'd be interested in that. The other one is about digital services, and I think there's I think we can probably get more digital services out in the community and get more people to adopt digital services in terms of digital appointments and things, if there is the support there to do that in the community. And there's an organisation which does work for care for particularly elderly and vulnerable people around Huddersfield called Aspire, who you might have come across. They're doing some plug and play tablets with really simple instructions, press this button, etc., to enable people to get online and use those services. And so I think rather than seeing what people do at the moment, what can we do to proactively get more people online using digital services? And that might change the approach that we have. And so I think it's not a passive thing that we're involved with. We should be actively involved in that. And the last one really is about the sustainability aspects of the report. Now, I've had a look at the sustainability and net zero aspects that are written about in here. What there isn't reference to is the West Yorkshire Combined Authority target of a zero carbon economy by 2038. So that's only 18 years away. So basically, the things that we build today should really be built to much higher standards. And so I look at this and think it would be an absolute disaster, I think, if a high energy user like hospital services was simply built to the rather lackluster building regulation standards that exist in the UK today. And so I think we ought to be looking for high standards, and also because that's about running costs as well. It's about the running costs of buildings, and hospitals being high energy users. I think it's got to be looked at. So looking at the very best in practice, we look at somewhere like Frankfurt, the new hospital in Frankfurt, where they built to passive house standards, which are high efficient, high insulation standards, mechanical heat recovery by ventilation, air tightness, actually healthier buildings to actually be involved with. And so I really would recommend looking at that and some of the work of the Passive House Trust on it. So I'll drop in the chat a link to Frankfurt, a case study about the Frankfurt Hospital Passive House.
Okay, thank you. Anna, did you want to come back?
Yes, just on that, just in the order around the involvement and the reference around the lower numbers that participated in the design workshops at the end of 2019. I think that is part of a continuum of involvement of the public over a number of years, as you're very well aware, around the public consultation.
Sure.
And absolutely, as I said earlier, we want to fully increase that, and you suggested any methods to enhance the uptake and opportunity. We'd welcome suggestions. The second around digital and digital exclusion or inclusion, what more can we do to support people to use technology? We're really keen, again, recognising we're reaching out in both councils around public health colleagues and others in the councils around expertise, and with voluntary organisations to really support people in the use of technology and ensure that we don't lead to a widening in health inequalities. And then the last one, really helpful comments around sustainability. In fact, we have undertaken more work around our sustainability brief, and the more challenging target of 2038 we have taken full recognition of. We have a broader document set out stating an ambition for us to achieve BREEAM very good, aspiring to excellent, and referencing elements of the Passive House standards and WELL that you've referred to. So that's currently in development. We'll look very closely at that link you've provided for us. Thank you.
Yeah, I'd be interested, and I think there's other folks as well who'd be interested in helping, who are involved in green building networks around West Yorkshire.
Thank you.
Okay, thank you. Councillor Simpson.
Thank you, Anna, Carol and Neil, for your updates. If I can start by saying it's nice to see everyone again. It feels like a very long time ago since we saw each other at the last meeting. I just wanted to ask about something that isn't included in the update but has happened since we were last able to meet. On the 2nd of April, the Health Secretary announced a package of NHS debt being written off. And on the 9th of April, they published a regional breakdown of how that would look. And from my understanding of that table, the total that was written off for Calderdale and Huddersfield Foundation Trust was 140.7 million. Might be able to give an update on whether that financial context has changed the effect with regards to reconfiguration and service delivery. Thank you.
Anna, is that yourself?
I will. I can answer that in part, but I can provide more information, in which case I will refer you to the Director of Finance. But that money that wrote off a legacy debt that we had did just that. It wrote off the debt. It didn't give us any increased revenue spending power as a result. So to some aspect, it has improved our accounting position in terms of that debt. Apologies for that phone ringing. My husband's answered it. But it hasn't given us more wherewithal of money to use going forward. And I'm conscious Neil's on the call and may well want to come in as well on that point.
Neil, did you want to come in?
Yeah, it was just to confirm it's very much an accounting thing rather than gives free cash to help with sort of affordability. It helps with some sort of interest payments. I mean, it's good news, don't get me wrong, but it was very much a smoothing of balance sheets rather than any real cash investment to help with the affordability of things going forward. Helps with the long-term viability of the hospital, but it's very much a balance sheet thing rather than anything to help with the I&E.
Okay, thank you. Howard, did you want to come in on this on finance?
I did, if that's okay. Thank you, Chair. It was in relation to providing us an update with the current situation with the PFI in Halifax, particular. It's my understanding that this is to be extended in terms of years, because I know it was one of the worst examples of PFI in the first instance. You know, cost an awful lot of money. I understand it's with the Department of Health and Social Care at this moment in time, and they're waiting to sign something off because I think they were looking at different options in terms of possibly buying out the PFI. So potentially an update in relation to where we are with the PFI in particular for Halifax and Calderdale, and what impact this has upon the on future plans, whether it's enhances or causes some more challenges. So that would be most helpful. Thank you, Chair.
Anna, is that yourself or Neil or Carol?
So I can give again some broad information in relation to that. In terms of the existing PFI in Halifax, there is dialogue around the current arrangements for that and how we can improve on that and do that in a way that enables this development on the Calderdale Huddersfield site, the additional works on that site to happen. You're correct, obviously, Councillor Blagborough, that has been some dialogue involving colleagues from Department of Health in relation to that. It is a discussion that we want to do to minimise as you say, the burden of an expensive PFI and to make the best use of that asset for the longer term for our population and around the environment of care. Again, it's a more technical financial area, which if there were specific questions that you wanted to raise, I'm sure that we would be able to arrange for that information to be provided outside of this meeting.
Thank you. I think that would be good if you could provide the committee with that information. Councillor Hutchinson.
Thank you, Chair. I would like to reiterate what you said about our need to be assured about the capacity of community and primary care services, and that and the impact that has on the design of the hospital services in due course. We've heard quite a bit about organisational restructuring and descriptions of the service, but what we need to see is outcomes from that redesign. And I would like to ask how the members of the panel think would be the best sources of information that would be able to give us the reassurance we need to recommend these reconfigurations. So how we can go about getting the actual detail of whether the changes that have been put in place are actually achieving what needs to be achieved. I'm very glad to hear about the accelerator status that Greater Huddersfield CCG has obtained for the urgent community response teams, which are a feature of the long-term plan, that's going live in November. But I would like to just caution against speaking to members of community health services and public health services in Calderdale. There are definite concerns that since the onset of the pandemic, that the coordination between primary care and the other health services, community and public health services, leaves some room for improvement. That it's not the kind of team working across primary and community care and public health that we might hope for. I do have other questions about the post-COVID learning that will have influenced the hospital design, but can I come back on those?
Anne, are you coming in on those? Or is it CCG?
I think it's CCG.
Carol or Neil? Carol?
I'll come in as Colin's sort of alluded to. It's mainly Calderdale. It's quite interesting to hear the comments around it not being as joined up. It's probably contrary to what I'm sort of hearing in other arenas. So it'd be interesting to understand sort of where those are from, because we've actually, I think Councillor Blackburn might sort of confirm, been portraying quite a good joined up approach between social care, health, primary care and community colleagues during the pandemic. And we've actually had some really good sort of feedback about how joined up services have been, particularly some of the end of life stuff. So I think we sort of need to understand that in a little bit more detail to be able to respond, because it's not sort of what I've been sort of hearing. The focus very much that we sort of have been hearing is around access to primary care, which Megan talked about earlier, and the digital first approach and the perception that GPs aren't open. We're doing quite a lot of communication out there to reassure that GPs are open, but unfortunately are very much telephone contact first. And then we are looking to ensure that all surgeries are open for some form of face-to-face in the coming months. But that obviously depends on the safety of patients and the safety of staff in the sort of the changings of the pandemic. So it's sort of a bit disappointing to hear, Colin, because I think everyone's worked really hard during the pandemic to ensure really seamless services and to ensure better joined up. As I said, some of the additional roles have been done in partnership with CHFT with regards to sort of physio, and we're working with other partners around the social prescribing as well. And we're having very much a system conversation about how these new roles are fully maximised and for the beneficial of multidisciplinary working. So it's very much at the forefront of everything we're doing with primary care. It's definitely not dropped off the agenda, but that's not to say that there won't be the odd occasion where communication isn't always perfect.
Colin, did you want to come back?
Yes, I'd be very happy to pick that up with you, Neil, outside of this meeting, if that would help.
It would, please, yeah.
Yeah, certainly. I'll drop you a line.
Okay. Did you have a further question, Councillor Hutchinson?
Yes, I did. It was, thank you. It was really under the influence of the pandemic. I mean, we know that the NHS was not in a good place in January before coronavirus struck. That there were across the country, there was something like 4.6 million people on waiting lists, and the numbers were increasing rapidly. And accident and emergency performance was at its worst level for many, many years. So we weren't in a good place, and part of that could be attributed to the shrinking down of physical space available, as well as workforce problems. But I wondered whether there were any changes to the assumptions that underpin the strategic outline case as a result of the experiences of dealing with coronavirus, the inability to run both an emergency response to the pandemic while continuing all the rest of the functions of the health service. You've mentioned an increase in the number of single rooms that are now featuring in the plans. But single rooms, I'd like to know how observation of inpatients in single rooms is much more difficult than in open wards, and they require a much higher level of nursing staff on wards to actually service single rooms. So whether the ongoing costs, safety and privacy, how those are all being put into the balance. We know that with airborne infections, that ventilation within hospital buildings, as well as physical spacing, is particularly important, and whether those are being built into the design brief that's being given to the architects and technical designers and healthcare planners that are going to be involved in the design of these buildings. It's just we need to be designing the new hospital accommodation for a post-COVID world, not for a pre-COVID world. So I'd just like to know what changes have been put in that would be different from those that were in the strategic outline case.
Anna, you want to come back in? Yeah.
I was actually going to suggest that perhaps my colleagues Rob Moisey and Mark Davies, as clinical colleagues, might want to respond to those aspects around the design features and how that improves functionality and the learning from the pandemic. If I could invite Mark or Rob.
Yes, please. Rob has indicated, I think. Rob.
Thank you. I'm Rob Moisey. I'm a consultant at CHFT. I'm also one of the clinical leads for reconfiguration. So we've had a number of external and internal consultations around the design brief and specifically around the ward design. There's been a lot of discussion around the configuration in terms of side rooms and open bays. And Colin, you're right about the potential for isolation within rooms and possibly the issues around observation. The architects that we're working with have had experience of building hospitals with 100% single side rooms, and they've got a lot of good ideas around ensuring good observation, how you can design the walls to the internal walls to facilitate some of that. So I think you're right. There's that potential, and certainly within the developments, and as we move towards the outline business case, factoring in the impact on workforce models will be part of that, because it may well require a different workforce model to manage those and to nurse those wards. There still is, I think, a clear demand for bays, Those bays would be ensuite, we would have ensuite facilities, but we recognise that there are a cohort of patients that actually prefer to be in bays, and the feedback we've had is they prefer that opportunity to be in shared accommodation with other people. Some people prefer the privacy. Some people prefer that more sort of social setting. So I think the architects, and there's been a lot of internal discussions around what the ward configuration would look like to ensure we get it right from an infection control point of view, patient care perspective, and a workforce element as well. So I don't think the final design hasn't been set yet. There's still conversations happening, but very much pre-COVID and post-COVID infection control was one of the key factors in the design. Thank you.
Councillor Hutchinson, did you want to come back? You're on mute, Councillor Hutchinson.
I'll get this right one of these days.
I know what you mean.
So that's very helpful to hear what stage things are. And as I say, there is a much greater understanding about the need for specific ventilation solutions to reducing hospital-acquired infection and transmission of infection between patients as well. But I did also wonder whether NHS England are requesting that health systems set up community diagnostic hubs and rapid diagnostic centres out with hospital settings. And I was wondering whether this was something that was intended for Calderdale and Kirklees, whether this was something that would have an impact on the provision of diagnostic services within the hospital base, and what knock-on impact that would have on diagnostic capacity within the hospitals. Because obviously, if you've got greater MRI, CT scanners, endoscopy units that are within the hospital, they can be used for both inpatients and outpatients. Whereas if they're out in the community, they can only be used for people in the community.
Yeah, I think Mark's indicated, and then Rob.
Thank you. I'm Mark Davis. I'm consultant in emergency medicine and another one of the clinical leads for the reconfiguration. I think coming back on what you mentioned, Colin, about sort of the air handling, etc. Certainly, one of the things that we've done in our emergency departments over the pandemic is to segregate between sort of a possible and an unlikely COVID patient. So we're running two, and that's part of our planning going forward as we design our emergency departments, is making them future pandemic proof or pandemic ready. So that will include the ability to split them into at least two parts, each with their own air handling unit. And that'll be part of the work that we do through the design both for Huddersfield and at Calderdale. That's something that we're already on with. I think the other bit was the learning from COVID. We had spent an exercise a few months ago, just as we were coming out of the first phase of the pandemic, where we met with all our clinical colleagues or groups of clinical colleagues to find out what they'd learnt from the pandemic and how we could use that going forward. We called it business better than usual. So rather than going back to business as usual, how do we improve on what we were doing? And I think what we found that a lot of the changes and sort of transformation work that we were thinking we might want to employ as we move through this reconfiguration, a lot of those changes happened very quickly, like the digital transformation. And while that wasn't necessarily the way we would plan to have implemented change, it meant that the change happened very quickly. And there is some work to go back, particularly around things like we talk about those people who are not keen on digital appointments and how we engage those going forward, so that we make sure that the people that haven't necessarily gained the most they could from the changes we've made are able to make the improvements that we would like them to make, and how we can cater for their needs otherwise. So I think that's quite important. In terms of the community diagnostics, we're going through a process at the moment where we're engaging again with all of our clinical teams of how they would like their clinical services to look in the future, what innovations are on the horizon. And as part of that, there are some of them who are suggesting there's increased opportunity for diagnostics in the community. So we're working through that, and that will again form part of our final model that we need in terms of capacity for diagnostics in hospital and in the community. So that's part of the ongoing work that we're doing.
Okay, Rob, did you want to come in?
Well, thank you. It's just to respond to about the community diagnostics, and there's a number of different models that we're considering at the moment. They've all got their advantages and disadvantages. I think if we build a diagnostic unit somewhere, it's a static unit, and it's convenient for some people, but some people will still be needing to travel. There are options to have diagnostic mobile units that might use GP practices, for example, or other suitable facilities. And we had a discussion, Mark and I were in a discussion, I think just yesterday, where we were looking at or discussing the possibility of a mobile echo unit where they would travel around. The echo machines are big, they're heavy. It would require an appropriate mobile unit, but that's an option. That means that it's providing that diagnostic much nearer the patient's front door.
Okay, thank you. Does anybody have any other points they wish to raise? I'd like to clarify about your business cases, please, and your design brief. So the design brief was done in February 2020, and we've discussed infection control, etc. And I was wondering if there was anything in this design brief that would be adapted or changed in relation to the experiences of the last few months. But also I would like to clarification for the committee on the business cases, please, because in your report you mentioned the content of the outline business case and full business cases. And then your table on page 14 of our papers states about a submission of a full business case for Huddersfield at June 2021 and submission of an outline business case and then full business case in Calderdale. Can you clarify, please, whether it will be one outline business case that you will be doing for the whole of the reconfiguration, and or will you be doing separate for Huddersfield and separate for Calderdale? And will the full business cases then be the same, or will they be different? Anna, is that yourself? Or Rob?
Well, I was just going to, in terms of, so what changes have we made in response to COVID? We can give you a good example with the new build or the design of the new emergency department at Huddersfield. Mark may want to come in, but where we've had a majors area and a minors area, it's very much designed in a way that the rooms are more generic, so that and equal size, so that if we need to split the department into COVID-free and potential COVID areas, it's a lot easier to do that without limiting capacity. So that's one live example where the ED design is very much with a pandemic, COVID similar pandemic in mind.
Mark, did you want to come in on that at all before I move to Anna?
Yeah, pretty much exactly what Rob said. It's about what pandemic has done is made us realise we're at risk of pandemics, and the part of the learning, while we're not planning for another pandemic, we're planning for the potential of another pandemic, and that's the way it's being ready for the next one rather than just planning for as we are now.
Thank you. Anna, did you want to come in on the business cases?
Yes, I will do. the outline business case that's referred to there around Calderdale Royal Hospital will encompass a description of the entirety of the service reconfiguration changes for CHFT as a whole and the benefits that will deliver. But it will articulate within that the significant capital investment at the Calderdale Royal Hospital. The reason why there are two slightly different processes on the business case is that when in 2019 we had envisaged doing a single business case for the entire reconfiguration, the recognition of the need to make the capital investment into the Huddersfield site as soon as possible to address some of the critical infrastructure risks that we have there around cladding and other works of improvement means that the agreement we've come to is that we can expedite that investment into Huddersfield by separating out that element of the capital build into a standalone business case for Huddersfield. The difference between an outline business case and a full business case is that at full business case stage, you have worked up that business case working alongside a construction partner, and therefore you have a surety around your pricing, as opposed to an outline business case is based on your cost estimate that is subject to your then going through a procurement exercise and working with your construction partner. So this is about trying to maximise the opportunity to have an earlier investment into our healthcare system, and that investment particularly where we have estate and building risk in Huddersfield. And does that answer the question?
Yes, it does. Thank you. So my next question then is the timelines for Scrutiny to be able to see these business cases. So if your submission dates presumably are June 2021 for outline for the whole of the reconfiguration and the full business case in relation to the Huddersfield building work, when would those be possible for Scrutiny to be able to look at? Do you have any timelines that you can give us at this moment in time, please?
You'll have noted in the report that we've put an envelope on the timeline. We will have completed those business cases by June. There are a number of factors that make me hesitate, and I'm sure you're very aware of them, around there is uncertainty in the coming months around the impact of winter, the impact of COVID. So in stating timelines, they have to be subject to a caveat, subject to the impacts of the wider healthcare system. Our completion of the business case in June, I think, would mean that we will be looking to have that dialogue in July.
Would that be before submission?
I'm not looking at the question there, Liz. I'm just thinking about the process in that we have a business case, that we will have approved a business case or confirmed agreement to a business case, and we will submit it to our regulators, who will take it through a process of diligence.
Right.
And there's something about the timing of at what stage do you apply a scrutiny to that? Is that before or after a level of diligence checking? Yes. Because otherwise we can talk about things that are then subject to change. We want to be absolutely have transparency around those timelines and process. And it might be something that we need to, as we move forward, that'll become clear, and I'd be very happy to have a conversation with yourself, Councillor Hutchison, and scrutiny officers to confirm those timelines.
Yeah, that's fine. I was just, I'm thinking as well that we might want something in the interim to discuss principles that you're using within those business cases, if you see what I mean.
I do.
So the business cases themselves will need as you said, will need the due diligence, but we, as a scrutiny, we may want to see principles that will be applied. I know that health inequalities has been talked about, and certainly within our original comments, we did say that we wanted the changes to address health inequalities that exist in both areas. So I think that's something within the principles of the business cases as well that we perhaps need to to be clear about as well. Okay. Does anybody, members of the committee, have any other points they wish to raise at this item, please? Councillor Hutchinson.
Yeah, just a relatively small point, and I do declare an interest that I represent Skirkett Ward, which is where the Calderdale Royal Hospital is situated. I see in the document that there's a section saying residents' engagement presumably in both Skirkett and Lindley about these changes, and that's anticipated in December 2020, which isn't that far away. And I was just wondering whether that was still the anticipated time scale, and if so, would I can think there's certainly I know for certain what one of the major issues is going to be that will concern residents, and it's just how much information you would feel that you would have to be able to put before residents so that they could have meaningful engagement with that process, if that indeed is the timetable that's intended.
Hannah?
So the intention, in keeping with planning regulations, is that we would have a meaningful engagement around our proposal for developments on both sites with local residents and stakeholders, and that would include being able to share design proposals, so that if there were elements where we could accommodate changes that were of concern prior to submission of formal planning applications. So the timeline, again, is subject to the caveats I've described, which are evident over the coming months, that we would want to be initiating that dialogue around December time to allow us to aim for planning submissions in February for Calderdale. And our aim, I think I said in my introduction, is that during the next few weeks, writing to local councillors in those areas, again offering to meet with them to inform them of what stage of the development we're at, in the information we've shared today about where the programme is at, and to hear views about how we have a meaningful conversation going through that pre-application engagement.
Okay, Councillor Blagborough.
Thank you, Chair. It was just picking up on the Brick House Health Centre. I don't know if someone was going to look into that particular case and seeing whether there is a case for actually going into further talks or actually looking into the feasibility, I guess, in some ways. So that would be helpful. Thank you.
Shall I answer that, councillors?
Yes, please. Yes.
So we've had dialogue with our primary care colleagues for several years now. There is no development in Brighouse at this moment in time. I have become aware that someone's put in a prospective building application, but that isn't supported by us or by any of our local practices. So there isn't a development in Brighouse at this moment in time supported by us. Okay.
Did you want to come back, Howard?
Yeah, no, thanks for that. It was just purely, I know something as Matt Walsh had taken up initially, had talks with the guy that owns the actual land itself, and it was just really trying to get a position in relation to where we are. So I think you probably clarified at the moment. I think it's a useful something to think about in the future, that actually if someone is willing to do that and there's a piece of land there as equally, then I know it's had to go through loops to get the planning application in the first instance. And I think it was more not necessarily just about a medical centre, but equally about a care home facility as well at the same time. So there's a few different elements where it might be worth picking up at some stage.
Okay, thank you. Right, to round off this item then, I think we talked about looking at what plans you have for improving engagement. We talked about that. Capacity of community services, seeing how that will work. Sustainability of development and reducing emissions. There were 2 items on finance that you were going to come back with. The Director of Finance was going to come back with, you're going to ask him for a clarification on, Anna, I think. And if that could be in writing to the committee, that would be really good. So we have that earlier rather than later. We talked about digital inclusion as well, health inequalities, looking at the principles for the business cases. I don't know whether the committee would want to look at see how the design had been adapted before we get into planning. Obviously, scrutiny cannot be part of the planning process, but we may wish to discuss about looking to see how the design has adapted, as we've talked about, and then a discussion on timelines for the business cases coming to scrutiny. Okay, are those points, has anybody got any other points that they think I've missed in the discussion there? No? Okay, thank you very much. So thank you very much to colleagues from the CCGs and CHFT for coming today. We will move on to our next item, but if you wish to leave the meeting, thank you very much. Okay, so the committee will move on to item 7, next steps. Is there any points that the committee wishes to raise on next steps, please? No, we discussed everything in item 6, I think, haven't we? Okay, so if we look at those items, and we'll look to see when we need some scrutiny meetings coming up. Obviously, we need to be mindful over the winter months of the health service needing not bringing out consultants when they're needed during the winter pressures, and whatever comes our way in relation to coronavirus as well. All right, okay then, thank you everybody for attending this afternoon, and we will hopefully see you soon, but everybody stay safe. Thank you.